overview of our area is that our city is about 650 plus thousand, and our greater area around the city, metro area, is another 100,000, 120,000-ish. We are a truly here we are. We're a truly civilian city surrounded by a ring of military. And so we have Fort Carson, which is the 10th Mountain Division. We have NORAD. We have the Air Force Academy. We have 2 Air Force bases. We have Space Force. And they all surround the city, and interestingly have their own EMS. And so that's a whole nother element. So what I'm going to do here is talk to you just about how our system has evolved over time. As I said, we are a mainly fire-based system. Fire doesn't do primary transport. They do a lot of backup transport, but AMR is the contracted ambulance service. In our history, like many others, and I'm sure around here, is that we had a one-size-fits-all system where we had fire and AMR responding to every incident for any type of medical. We have joint PSAP. We don't have a secondary medical PSAP. We have everything is run in our PSAPs through physically through the law enforcement agencies, but the PSAP providers, call takers, will EMD every type of incident, be it police, fire, or EMS. And originally our response was when they would say, "What's the nature of your emergency?" and they said medical, then they just pressed a button and everybody is out the door before they even know anything about what's going on. Okay, and that's the way that we worked up until just a few years ago. And a few years ago, what we started to do was divide out ambulance-only responses, ones that the fire department decided that they didn't necessarily need to be going on. And for those of you who come from fire services, obviously that's a big cultural change, but it was something that our chiefs were willing to try, and it worked very well. And then what we did was we started to develop what we call our rainbow of alternative responses. Okay, so the most important thing that I'm trying to get across to everybody is, and I'm actually gonna just put it right to here. So what we ended up with is over the years, and this has been about a decade process. Okay, so we didn't just decide, oh, we're going to have tiered response, and then 3 months later, everything changed. We did this over a decade, and we did it by creating an entire another division within the fire department. It's called Community and Public Health Division. And then operations, the traditional operations, was sort of on the other side. And then all of these circles here represent the different types of programs that we have that divided out types of responses. Okay, so we have specific responses that go to the behavioral health crises from 911. We have a lot of these are 911 initiated, but then they aren't handled by 911 types of responses. But we have everything from aging in place programs for the elderly, homeless programs. Each one of these are separate groups of teams that do these things. Super utilizer programs, I'm sure everybody's familiar with super utilizers. And then our CRT unit is a joint police, fire, and behavioral health unit that circulates around and skims off the top of 911 calls to axle out most of the behavioral health calls in our community that come through 911, and they dispo them right from the field, and they never hit the emergency departments. And so the one that I'm going to be concentrating the most on is at about 7 o'clock, 8 o'clock, the community medicine called CMed. Okay, and so what we did was we decided in this part of the tiered response that we were not going to respond in the time frame that is traditional. Okay, we didn't do this based on the paper that came out recently. This was something that's been in the works for about 8 years and then really took hold about 3 years ago. And so we had to bring in all of the stakeholders here to make this work. And then we use this format, the DMAIC. I think that a lot of people are familiar with this. We first had to ask the question, what is our issue? You know, we can't continue to respond in the same time frame that we have in the past. And does it really make a difference? And what do we need to do to offload the fire department traditional responses, because we can't just keep affording more fire stations, more all-hazard employees, et cetera, et cetera. So we defined our question, and then we did measurements on those questions. And I'll go over some of these things in a little bit of detail. And we decided to come up with the measurements of what we wanted to make the difference in. And then we would analyze these after we would implement them to find out if we were actually having the effect that we wanted, because that's not a guarantee. All right, and then we would just go into a repeat planning phase and then control those new plans, and then go on and then just keep going in a circle all the time. So and I'll explain a little more about that in detail. The way we use priority dispatch, that's the entire state of Colorado uses priority dispatch. Colorado Springs is an accredited dispatch center and is very, very, very tightly regulated. I know we had a talk earlier about how that doesn't happen in a lot of places. Ours is very tightly regulated, very much holds to the protocols, and is QA'd all of the time to make sure that is happening. These are the elements. They use EMD for everything. Not EMD, they use the MD for everything: fire, police, medical, okay? The nurse triage thing over here in the corner, that's a theory, it's something that we're not going to go with. That's a whole nother conversation, but we don't believe that that's economical or practical in the way that it actually comes out in reality, not just on paper. So I think most people are familiar with this. You know, EMD has the 40 different determinants. And then they're rated from omega to echo in severity. But what we did was we really defined this differently, and we didn't want to do it by severity. We wanted to do it by time sensitivity, because that's where we were going initially with our tiered response. It wasn't that we were going to send necessarily only BLS, which we do on some of them, and I'll show you. But we wanted to know, when do we need to arrive to really make a difference, okay? And so alpha omega calls, which really aren't calls, and alpha calls in our system, with the exception of just a few alpha calls, are taken care of by BLS ambulance only. Fire is never involved in those. And then our CMed units will take everything from some alphas, and those are alphas that require some sort of ALS, like narcotic pain medicine, okay? And that's the only reason that would make it ALS, all the way into the deltas, okay? So it's a huge range of what is handled by the CMed units. The CMed units, by the way, are SUVs. They are not, by definition, transport vehicles, and they're staffed by an EMT and a paramedic, okay? And so obviously, well, not obviously, but our echoes are covered by regular fire apparatus and ambulance, and then a lot of the deltas, most of the deltas are also. CMed doesn't get involved in most of those, but they get involved in some of them. And so what we did in our definitions were to decide, these are the criteria that we're going to use to try to tier out when we're going to be able to send a CMed unit at an extended period of time to the patient. And we started with what we considered time-sensitive critical illnesses, unstable vital signs, and meeting ALS criteria, okay? All of those things there operate purely in the gray zone and need, further definition from community to community. But what we did here, just as an example, this is where we started. It's changed a little bit. Is our ALS criteria, we're not placing a monitor and starting an IV, which is often how people measure that superficially, because everybody's getting a monitor, everybody's getting an IV, even if they're not getting meds, and so we didn't want to use that. And so we went to some of the other criteria that really made us believe that this was something that an advanced practitioner was needing to do. We've actually had change in the scope because now OG tubes, IOs are BLS in our community. And so as time goes by, these criteria will change. I have to step over here to see. Okay. And this gives you down here just some examples of some of the determinants. And what we did was we came up with thresholds, okay, on what percentage of calls in a certain determinant were needed to have ALS criteria before we decided that needed a full response and not a CMed response. And we decided at 3% on this, okay? That was basically, we took something that was working in Fort Worth, and then we just started with that, because Fort Worth is very, very similar to our system. And so we were able to, what we call R&D, rip off and distribute their parts of their system. Time-sensitive criteria ended up to be very subjective, and we really were measuring this in the end by were people needing to have assistance in airway management and ventilation. That might seem strange, but when you really look at all of the data from all of our determinants over many, many, many years, and you pull it out with programs like Power BI to look at it, you can fine-tune what really were the common denominators in time-sensitive criteria. And so we did the same thing with that, where we came up with thresholds and percentage thresholds. I specifically do not have vital signs in there because at first we thought, oh, that's going to be a great determinant because if somebody's hypotensive, if they're really tachycardic, then that's going to make them more, more critical. But what we realized very, very quickly when we started to do this program, just as Fort Worth did actually, was that the vital signs really did not matter. Okay, they matter, but they were caught in the other two categories, okay? And that if we just went on, if we had a lot of the CMed responses or lack of CMed responses based on unstable vital signs, then we were going to a lot of people with the traditional response that didn't need it, okay? So we basically took that out as part of our criteria. All right, so how did we do this specifically? All right. What we would do is we basically took all of the determinants, and as I said, we're very, very strictly monitored with those determinants. I do medical direction for our PSAPs and the 911 authority. We don't have that many PSAPs. We try to consolidate them. In El Paso County, we have 2, which is the city of Colorado Springs, and then the rest of the county, and then the military is separate. But we all work together under the same 911 authority. And so we all use the same rules. So what we did was we decided to look at these and not just look at it as, okay, Alpha can go slow, Bravo maybe, Charlie needs to go fast, et cetera, et cetera. These clean lines that people like to assume are correct, but they're totally not, okay? And how do you determine that they're totally not? It's because we can take years and years of good protocol analysis and with a guarantee that the protocols have been followed. And we can look at exactly what happened in each one of those determinants very specifically and get these numbers very, very quickly, okay, through Power BI is what we use. And so these are all the operational elements that we would look at also, because CMed crews are smaller, et cetera, and we needed, and also they don't transport. Okay, so part of our whole reason for doing all of this, and I know nobody else deals with this problem, is that we had a lack of ambulances that could transport people, because we were sending ambulances to everything. And then AMR was always on a level 0, and we were just dealing with horrible issues with that. This program allowed us to cut down on ambulance transports significantly. Okay, so that was part of the parameters of what we did. These next two slides really explain the essence of how we divide everything up. We have a x-axis of time-sensitive versus not time-sensitive, and then a y-axis of ALS or more advanced procedures versus the less advanced procedures in BLS. Okay, and those lines are coming closer and closer, by the way. I think everybody knows that. The BLS is really encroaching on ALS, especially in our system. And so what we would do is we would start with a certain determinant. This is not dangerous fall with deformity. Okay, and so we started very, very mildly with this, with a kind of a low threshold of saying we'll extend this time period 5 minutes and see if that makes a difference. Okay, so this was just our entry point. Okay, because if we went to the city administrators, if we went to the mayor, if we went to the citizens and said, hey, we're just going to respond when we can, that may be an hour, that may be whatever, but don't worry, we'll get there during the time-sensitive things. People don't accept that. We all know that, okay? And so the way that we tried to do this was to go stepwise. And so then, but we had a whole range of protocols. We had other protocols where we went to more than doubling the time of the traditional response. And then now we're even moving much further away from that. And because we've been able to prove with the outcomes that I know Colby said that I said that there was not one adverse outcome, but let's say that there are very, 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 very few adverse outcomes, and I'll explain what I mean by that. But this is just an example here, and so we decide that basically all of our calls are going to fall in one of those 4 quadrants, and then that will determine the scope of practice that's sent, as well as the time frame that they can arrive in. Okay, all right. This I think is the essence. Especially for fire, okay, because I come from the fire world, of what difference our program has made in, the CMed program has made for the fire service, okay? So we basically have noticed that there's roughly a 30% of the time CMed was able to keep a fire company available for the really acute calls, like the cardiac arrests, et cetera, okay? And so, and then what it did was it decreased the run order deviations, which is basically when, I think most people know what that is, but just in case, it's just when, if we're off on a call in our district that is not critical, and then the next minute, a critical call drops, we're going to have even increased time to get to them than we would have normally, because we have to call engines out of the district to come, and we're not available for the time-sensitive calls, okay? And so I think it's a recurring theme, all right? But we were able to show a very, very big change in that. This would honestly also be bigger percentages, but the reason why is that I'm using the numbers for all of our districts. And the CMed program is still considered a pilot program after 2 years. We're working on the full expansion, but it's only in 2 out of our 6 battalions. Okay, and so when I take these numbers, this was an overall 30 and 33% decrease. but that takes into consideration all of the districts and battalions that don't have CMed, if that makes sense. So if we confine this to only the battalions that had CMed, we're getting way, way over 50%, okay? All right, and then the third thing is the decreased usage of ambulances, okay, which has really been huge. This is just an example of our deployment time-wise. So our CMEDs go from 6 a.m. to 9 p.m., now 10 p.m., and basically the red represents the numbers of calls per hour that we have just the engines and the regular responses going. In the middle of the night, CMED isn't available, at least right now, but we are going to be making it available. And so that goes into, rounding up in our data. When we talk about the overall system, we're talking about certain times where this program isn't available also, which actually will, on paper, look like the effects are much decreased, but they're still impressive even when they're decreased like that. And so these are our, we have actually 5 CMED units out there now. This was a graph when we had 4, and it can show you the relative, percentage of the calls that are taken by CMED offloading from the regular heavies, okay, which has been a huge deal. This is a very busy slide, but basically what the essence of it is, and this will be available for people in a handout, I guess. All of the slides will be. But it goes through many of our most common determinants, not all of them. And it basically is showing how CMED has been able to markedly reduce the amount of ambulance requests and ambulance transports to hospitals. Okay, so these are huge numbers. That changed AMR's world when we did this, okay? And so it was, these programs have shown nothing but really good results, 99.99% of the time. And so we're just gonna continue expanding. Okay, this is just getting toward the end here, but this is a specific example of how we analyze each individual EMD determinant, okay? And we did this for all 40 determinants and all of the subcategories within the 40 determinants, okay? And several years ago, we would have never been able to do this. If we couldn't collect this data in a timely fashion, if we had all of these questions, like I was starting in our analysis, we have the questions, just to obtain the data, if we turn the questions in, how many times do we do this, how many times do we do that, what are our time frames, et cetera, it would take 3 months for one of the data people to come back with the information because they have to go in and they have to pull it and everything. And so the technology advancements, and in our case, it's Power BI, has been able to allow us to answer these questions instantaneously when we have them. And we can do it over 1 year, we can do it over 2 years, we can do it over 5 years. We can collect all the data, get a lot of power in that data instantaneously for every type of question we have. All right, and so this is just one example here of a fall. This is with all this, suffixes in the falls, but it really shows that how we are decreasing the amount of ambulances. It's giving us exact numbers of traditionally how many times we have to take people to the hospital, are we actually needing an ambulance, et cetera. All of these, by the way, just a few years ago, got an ambulance and the far majority were transported to the hospital. Okay, so these are huge numbers. Just as one example here, the patients transported in this whole category, there's only 33% of them that are transported. That was more than double of that just a few years, just 2 years ago. And then we break it down into alphas, bravos, each type of subcategory within that within that determinant, and we can figure out exactly how many times we needed ambulance transports, what type of, were there ALS criteria met, were there only BLS criteria met, was it time sensitive, was it not? And we don't do it based on what the determinants say on the front end. We do it based on what was found on the back end per determinant, okay? Which is why it's so critical to have really, really established protocols that are followed, okay? Because the system is worthless if you don't follow the protocols and have some sort of QA process that makes sure that the protocols are followed. Then you have no foundation on which to do your analysis, if that's the case. All right, and then we go to Bravos, same sort of thing here. And then we would go to Deltas. And then we would figure out, are our thresholds going over what we want for CMED? Are they falling under? And then that's how we would establish when we could appropriately send CMED on a much longer time response. This is another one. I'm not going to, same sort of thing. I'm not going to go through it. Just gives you an idea, another idea. I would say that we have, well, there was one thing I wanted to show here. Yeah, this one right here. Protocol 32, which is the unknown medical, all right? Everybody's favorite bucket, all right? And so this is where it's really, really important that the protocols are followed. Because this is often the axle out for the call takers. I'm not saying anything bad about the call takers, it's just that the information that they can give on a dispatch is only as good as the information they're receiving from the people on the other end of the call, okay? And a lot of times that information is not very good, all right? And sometimes it's non-existent. And then you end up with these unknowns. And then if there's so many things that are unknown, then you end up on deltas, right? Because nobody wants to make the mistake of like, well, we're not really sure, so we're just going to send everybody and we're going to make it really, really high. Okay? Well, that's great, theoretically, if you operate on what I call the boogeyman complex, where, you know, you have to run an entire system based on what's going to happen, like, you know, 0.01% of the time. But what we were able to do was really analyze through Power BI, all right, on these, how many times are we really using ALS? How many times are we really transporting or even needing an ambulance? And then we were able to say, oh yeah, this is totally fine for CMED to go to. We're not going to be transporting these people most of the time. They're not time sensitive most of the time. And then we just come back and we check it all the time and we make sure that we're not missing something or there's not a trend in a different direction. But this is just one example of how CMED gets into all the way up into the deltas on the scale for medical priority dispatch. This is these last two slides are basically. Last two slides are basically showing that we have to have continuous feedback, continuous analysis of the system. We cannot put anything out based on a theory or based on what worked in Fort Worth, and we just assume it's going to work for us, because a lot of systems in the past, at least from my history, I noticed in the fire service specifically, but that's what I work in, is that there are programs that are launched, and especially on the medical side, and then they're never reviewed. And then they go off into the future, and then 3 years later, we're looking at things, and the program isn't anything like it was when it began, but nobody's ever bothered to look at where the creep was, where the morph was, and keep everything in line and adjust by real information and real data as it comes in to keep everything on track. And so these are really important things. We have to get all the stakeholders involved. We work very, very closely with the dispatch centers to make sure that we're all on the same page. Everybody has to be on board with this in order to make it work. Okay, the dispatch centers, the fire command, okay, I'm just telling you, if you don't have a command that, that is willing to think forward and outside of the traditional box, at least in our system, then we go nowhere. Okay? And I don't think that it's very foreign to say that sometimes a lot of the change in the fire services come with retirements. Okay? And I'm just being realistic. And you know, when we went through that process, we had chiefs that just weren't interested in EMS at all. And then eventually we grew into having chiefs that were all past paramedics. And then a lot of them that were able to think outside of the box and allow us to create full other divisions within the fire department that don't operate under the same system and rules as the rest of the fire department in order for these innovations to occur. All right. One of the things, and I'll stop, so if you want to come up, is that we had a lot of unexpected consequences of this because we just assumed that everybody on the line was going to be beyond themselves happy when we launched these programs, okay? And for the most part, they are. They really are, especially in the beginning, the behavioral health units, because all of a sudden out of nowhere, the fire line was not responding to the far majority of behavioral health incidences that were happening in the city, okay? And that was huge. Same thing with the ambulance service. But for CMed, when we brought CMed in, and we brought it in the two busiest battalions, all of a sudden, they went from having X amount of calls to 1/4 the amount of calls that they usually run on. And these are people who they thought in theory that would sound good, but some of them actually came back to us and said, we're bored. Okay, we're not really doing anything. Can we take some of those calls back? And we're like, no, you can't take them back. But we weren't expecting some people to actually be upset. And there were some people that were saying, well, I want to move stations. I want to go from our busiest downtown station, I want to go out towards the mountains where there was sort of a medium busy station, but it doesn't have CMed. Okay, and so there's a cultural change that has to happen. We didn't really recognize that. We just assumed that everybody was going to be totally happy with it. We've been able to get over this, by the way. But it was just one of the interesting consequences of that. So, and with that, I think I'm done. And we'll pass it on to Dr. Daya, and I'll be available for any questions during today. This is perfect. Is that you?
That's me.
Great. You can sort of see 3/4 of the screen.
Not to worry. So I want to thank Colby and I want to thank MedStar for the invitation. That was a fabulous talk. I'm also very much of a fire-based EMS medical director. I hail from Portland, Oregon. That's where I live, although most of my work is done in Washington County, Oregon, which is a single center dispatch. It's a model very similar to what is in Colorado Springs, which is fire first response with ambulance transport, although fire does back up the ambulance when they get down to level 0 from time to time. So there's sort of a hybrid model. I work with a number of fire agencies. The largest one is Swamp Valley Fire and Rescue, which is a fire district. We cover 11 cities, and I'll go through 3 things that I think has evolved over time. I'm also the 911 medical dispatch director, which allows me a little bit of insight. I don't have as much data as he does, but I think we'll go through this because I think you can make changes in the system. And I think the work that Dr. Kupas and others have done through NHTSA on lights and sirens and reducing that, I think has been something we've been focusing as well. I do have some disclosures. I do a fair amount of research. My personal area of focus is on cardiac arrest and resuscitating patients who have had sudden death. That's been my focus over the years. So I've participated in a number of projects and I have funding from number of entities that work on that. I'm currently working on a project with ARC through NHTSA to look at the evidence behind blood transfusion, which I hope will have a report out within the next year for everyone to have to review. So this is Washington County, Oregon. It basically is the western county in the Portland metro area. It has a number of cities, as you can see, and it's also got quite a bit of diversity in the sense there's a rural component, there's a suburban component, there's an urban component, which makes responses always challenging in how you put it together. And that's basically what we're going to get into. This is the second most populous state. It's about 600,000 individuals live here. The county seat is in Hillsborough. The two biggest businesses in the county are Intel and Nike. And then we have 4 receiving hospitals, 1 comprehensive stroke center, 3 are primary stroke centers, and we have essentially 2 STEMI centers in the community. 1 is sort of part-time, so that's why it says 2 to 3. The system has evolved. Prior to 2003, we have probably one of the more expensive EMS systems that you'll find in the country. It's a dual ALS system with both fire and also EMS, which was provided by a private company called Metro West, which was also providing ALS. There were 2 dispatch centers at that time. The 911 center that I work with was basically an interagency governmental agreement between fire and police, and it basically used the APCO system. And then Metro West was a separate ambulance company that had its own dispatch center. And at that time, metrics are largely based on response times, much on geography, and we'll talk about some of the changes that have occurred. Since August 2023, there was a new RFP for the whole county, and now we have a tiered response. So the first thing we've added is actually a BLS option in terms of the ambulance. So we don't always send ALS ambulance. We are trying to send more BLS ambulances for the same reason that many of them don't need ALS level skills. We have moved to a single dispatch center that does everything so you can track the data. Tracking data is really key to tell you how your performance is occurring, both at the dispatch as well as the field level. And then the change, which you'll see, is that the operational metrics for the ambulance service area in the county is no longer just based purely on operational. Operational metrics exist, but we now also have clinical quality indicators, and those are used to offset some of the penalties that you might occur when you don't meet operational metrics. So that's kind of how the system is being set up. So let's get a little bit into the 911 center. So the Washington County 911, as I said, now dispatches police, fire, and medical. The things that we've been looking at for a long time, so when I started working with the dispatch center, everything was lights and sirens. It was 100% lights and sirens. And so we started off with the cards to figure out how could we come up with things that did not need to go lights and sirens. Since we use APCO, it's not the Alpha Bravo, but it's more code 1, code 3. And so the first cards we worked on, not surprisingly, were abdominal pain, back pain, as A and B were the easiest ones to work off. But then we've added falls, and we've added trauma, and the one I'm most interested in taking is the sick unknown or the medical unknown. Basically, that's where we send a lot of unnecessary calls. Part of the problem with dispatch, I think, is that the information that you get in is often what drives the response, and also at the dispatch level, that's the culture you need to also understand, that the dispatchers feel that getting something done is a quick response to fixing something, but often it's actually the inappropriate response, because if you cause a collision on the way to the scene, that's not accomplishing anything for anybody. So we started tracking this data. We went from 100% code 3, which is in red. We went down to 80% after the abdominal pain and the back pain card. Then we got stuck. Then we reworked the cards, and now we've been able to get down to 60, you can see it's 60.830, so it's 60/40. Am I happy? We have a ways to go, but I think that's the goal, is to ultimately get forward. But the good news is when you look at the cards that actually have a code 1, code 3 response, we're 50/50. And I think we can continue to work on these as well. So, and part of this is to take data from the back end. And you can see the one thing that does happen when you introduce a BLS component and you introduce a code 1, code 3 component, the call taking time goes up. It's not as fast as it used to be. So you can see the top green line that we've gone up to about 2.5 minutes to process a call. This becomes an issue if you have a lot of calls in waiting. And so you've got to think this through. And so you got to make sure you have enough dispatchers to be able to handle when you add that extra workload of actually getting more information so you can actually process the call and send the appropriate response. One area, as I told you, I focus a lot on is cardiac arrest. We use something called the no-go. If they're not conscious, not breathing normally, we go full lights and sirens and it's dispatched quickly. So you can see we try to get that out within a minute or 90 or a minute and a half, and we're able to achieve that. And that's one of the key things that we do is so the three things that I monitor really closely are the three time critical emergencies to me are cardiac arrest, choking, and then childbirth. These are the three C's as I call them. I like what was said earlier today about bleeding and airway control. Those are the other ones I'm going to add into the system. But this is what you want to think about. There are times when we really make a difference, and there are other times when probably a few minutes doesn't make a difference. So you need to be able to separate that on the back of your mind as you think about how you want to organize your EMS system. So this is what we do. And the most recent thing we've been monitoring a lot is did we get the right response out? So did we get an ALS response when they needed it and a BLS response when they needed it? Again, I don't have the sophisticated data that Dr. Bronsky showed you, but you can see that over time, as we've introduced a BLS tiered system, we've actually been able to get the BLS out more often, which is the blue ones, the orange ones, and we're actually getting less and less transfers from ALS to BLS. So this, again, is an evolution, but you have to track your data. Everything is about data. You should be data-driven in everything you do in EMS, and the more data you track, the better you'll be able to refine your system. Perfection is hard, and I don't expect anybody to be perfect, but you need to be understanding that the goal is to be like a fine wine, get better with age, and that's kind of the goal for all of us in EMS. I will tell you that I really admire what dispatch does. I think that they're often unheralded in this process. We have worked a lot over time to actually work on cardiac arrest because it's one of the things that people can visibly see. And so you can see this is comparison of our regional data, Oregon National, and then the three counties that surround the city of Portland. And you can see that Washington County's bystander CPR rate is 70%. And a good chunk of that is the dispatchers. There is no, would you like to do, you will do CPR and we're gonna count with you and you're gonna do it this way. And I'll tell you that this translates into the survival rate, which for a witnessed VF is 45%. Am I happy at 45%? No. We can get to 60%, 55, 60%, which is where the neighbors to the north, the King County and the Seattle's always sort of, but we've talked about how people count numbers slightly differently, but I think that we can get to 50 or 60%, but it's going to require a little bit more refinement in what we send, and we'll talk about some of that when we talk about the fire responses. So that's a bit about our dispatch center. What's our focus going forward? We're adding a nurse navigator piece in. I also agree with Dr. Bronsky. I do not think that this is necessarily a fix. I think that people in our community who have major healthcare systems that already have nurse advice lines tend not to call us if they have a thing that they can call the healthcare system. But it may work in some communities. But we're going to play with that. I really want to increase the BLS unit dispatch. That's my goal. I think most calls can go BLS, but we've got to figure out these cards and make sure that we can work with them. I don't like fire going to urgent cares, doctor's offices, fixed facilities like psychiatric hospitals or mental health units, which have nurses and physicians. So we're working on that. Each dispatch card is looked upon. There's a quality review. And then we actually have created a culture where we don't have a constant cards that never change. We work on cards. We get the floor, we get the dispatchers to come in and we work collaboratively so they have the buy-in. So it's their own peers that are helping improve the system. So that's where we work on those cards. Let's talk about, I'm going to switch now and talk about the Washington County ambulance service area. As I told you, this got changed in 2023, and I gave you the new model, but I'll sort of talk about the franchise agreement, what's in it. So as I said, there are operational metrics that are the same as typical ones, the big ones being response times and then level zeros, because AMR is the transport provider now. But there's also clinical metrics now built in. The first one that they rolled out is quality of CPR, but others are going to come, such as STEMI, stroke, airway, and each of those are actually going to be part of the of how the system performs. So just from a response time, you can see that there is no 8-minute magic mark that people have talked about in the 4 and 8-minute marks. In the urban areas, for the lights and sirens, it's 10 minutes for the ambulance. In the more, if it's a code 1, it's 15 minutes. And then the level 0 is basically when there's not an ambulance immediately available. So you can see that the response times are longer than we're traditionally used to seeing. And I think they will continue to get longer as we get more and more of the BLS response, because that's 15, 17, 40 minutes. That I think is, in the long run, still going to be good. The main thing we have to watch is outcomes, which we're also tracking closely. So what are the kind of performance metrics you can come up with? So these are actually published and available for many people to use. You can look at NEMSQA, you can look at other options, but all of these exist. I'll show you some data, but we have quite a robust STEMI program, because we have 2 STEMI centers that give us feedback data, and we collect that data very closely. We also have quite a bit of cardiac arrest data. Again, as I mentioned, that's been a focus of us, of our efforts in the region. And I'll show you some of that data as well. So this is some of our STEMI data. This is basically an ECG done within 10 minutes of arrival of anybody with ischemic chest pain. You can see that it's done pretty quickly. This is looking at the ECG being transmitted within 5 minutes of the STEMI being identified, so that the cath lab can be activated. On weekends and night hours, the team has to come in from home, so gets that whole process moving really fast. Again, we have most of the times we do it within 5, but there's times when we actually take 10 minutes, but still, this is an area we work on. And then this is actually getting aspirin on board, and we were pretty good at getting aspirin on board on every patient as well. This is some of the CPR data that's now being used to look at AMR's performance. So the things we're looking at are chest compression rate being between 100 and 120. We're looking at chest compression fraction. The limit there is at the bottom line of 75 or 70%. And you can see that there are some changes, and I'm happy to go into them if you want to understand why. But one thing about these metrics, if you change your system, like we went from doing continuous compressions to doing 30 to 2, that changes your metrics. And so you have to be really good about making sure that your metrics change appropriately with the kind of care you're delivering. You can't expect the same metric if you change the delivery model. These are the pause durations. They're supposed to be less than 10 seconds, so we're watching these. And then these are looking at any pause above 10 seconds to understand why. The biggest area here of focus is the mechanical CPR devices. When you bring them in, if you're not watching carefully, you will get pauses of 45 seconds, and then not surprising, your survival will drop. So you have to basically watch this closely. Everyone loves the machine, but putting it on and getting on in a timely fashion is also an art of work a system has to pay attention to. As I said before, AMR in this particular contract will be penalized if they have response time issues or their level 0s are pretty high, above a threshold, but then they get incentivized. If they meet certain quality metrics, those are actually used to actually offset the penalties. They don't get money back, but they get their penalties reduced by basically meeting benchmark metrics. So it's an interesting agreement. We'll have to see how it works. It's 1 year into the process. And whenever you change something, it takes time, but that's currently what we're working on. What are some of the challenges? So I think data collection is an issue. We have a dual system. We have fire, and we have a private ambulance company like AMR. So we do have to make sure that things are clearly about whose data is where. It ultimately belongs to the agencies, but then you want to have working together with DUAs. We're fortunate that all 4 our hospitals use one platform, which is Epic. And so that allows the potential for data exchange, health information exchange back and forth. Epic is still not there today, but we're working very hard with Epic to actually create a two-way interaction, which would ultimately, what really influences is what happens to the patient after they've been taken care of at the hospital if they're transported. Knowing that information is so helpful to drive how you improve your system. As I told, we're evolving KPIs in the BLS utilization. So this paper from Dr. Levy is a recent publication. It also highlights the same things, that we send a lot of calls hot, but they don't need to go hot. We can be much more sophisticated in how we do things, but you have to drive it with a data system that is 360, and you got to do that 360 PDSA cycle in your system. GMR, which is the parent company of AMR, basically has a playbook that it's put out. I'm going to just share you. These are some of the quality measures they're measuring across their locales. So they have cardiac arrest, airway. These are the metric drivers that they use, and these will be available in your slides as well. Similarly, that one for airway, I've just put some examples up. And these are the things that they're looking at. And you can see that these are things that are coming very much from the NEMSCO approach of actually looking at quality improvement and quality management. All right, to finish up with, so that we're back on time and I can see lunch getting ready here. So the fire agency I work with is Squaw Valley Fire and Rescue. I've been their medical director for about 30 years. We're a fire EMS service in the sense that we provide all hazard, but we also have the ability to provide some transport capability. We cover 400 square miles, about just over 500,000 people, and we have 38 stations, 28 stations. Somebody mentioned this earlier, we have 450 fire personnel, about half are firefighters, half are paramedics. We have 6 transport units that we use, and most recently we've reinvigorated what's called an advanced paramedic community paramedic or APCP program. These are the 4 fire chiefs I work with, so you can see that if somebody's talked about retirement, advancements are one at a time. I've been through 4, and probably will be a 5th one coming up soon. So we do transport, we do provide transport in a subcontract with AMR in Clackamas County. We transport in Washington County when the ambulance levels hit 0. And then we have our own ASA, which is in Newburgh, which basically we cover all 911 transports and also first response. So what are things that we've done which are innovative? And I also will say that I very much believe that it should not be an us or them approach in EMS. It should be a public-private partnership. To me, that is the most successful because I think it's very hard for EMS to function unless it's all part of one organization. But if it's separate organizations like we are, the best way is to work with public-private partnerships. So in Clackamas County many years ago, 3 fire departments sat with AMR and came up with what's called the consortium agreement. In the consortium agreement, we stopped the clock for AMR in response times because when the fire department arrived first, it provided ALS. As a result, AMR was able to save 1 unit in that county, which is a huge geographical county. That money that they saved has been put back into the system through something called a system enhancement fund. That's been used to, for example, support purchasing of VL equipment, 1280 equipment, ESO charting platform, which is now uniform in that county. So you can see that there are benefits that come, but you've got to be able to think this through. With TVFNR in particular, we are also looking at the high utilizer group. He called it super utilizer, we call it the high utilizers. So we've created these APCP cars. They were initially part of what we call a peak activity unit, but now they're molded into an APCP car. This is 1 paramedic in an SUV that responds on certain calls. Most of their time, they're actually working with the high utilizer group, but they're available to actually respond to any critical call. They can add themselves on to a cardiac arrest, an airway issue, a major trauma. So they can actually act as a coach. They bring additional skills such as the ventilator. Soon they're going to be bringing ultrasound to the scene, hopefully blood someday, if we can make it all happen. And now we're actually working with a pilot program with where these same units are used with an NP or a PA to respond to our care facilities. We have 77 in TVFNR as a district, which are a very high call volume for us. So we're trying to reduce the number of times that we go there or where we actually go and transport unnecessarily to the hospital. We can actually fix a number of the problems right at the care facility, because these units have lab tests they can run, they can check for UTI, they can check for a number of things that make things much more progressive. We also have, even though we're not a transporting agency primarily, just because we're a first responder agency, I still think we need to have our own key performance indicators. So we have a list of these that we've looked at. I've just shown you some of the things we have that we do. So every cardiac arrest gets a review, gets a feedback, individual to the crews, the crews get their feedback. It includes their performance metric on CPR, if they applied the Lucas, how long it took to apply the Lucas. Then they get additional metrics, they get their charting feedback, and then they lastly get outcomes, because outcomes drives everything. So I think I'm just going to end there, because hopefully we'll get back on time. So this is, again, most of you are familiar with the concept of reducing lights and sirens. What I'll tell you from my experience is that if you do it slowly and in a graded manner, it does work. It's really hard to just disrupt the system overnight. I think if you take your time and you do it, but you're watching what you're doing and you're making sure that you're doing it safely, I think you will get successful. I'll stop there and see if there's any questions. Thank you.
Sorry, I have 90 seconds worth of things that I wanted to say that I forgot because I was going fast before. One thing is, especially with finances, because finances obviously are a huge part of all these discussions. Our programs, all of the alternative response programs that we have, including the CMED units, are all civilian hired by the fire department. They're not all hazards and employees, and so it's much, much cheaper for our fire department and our city to staff those than it is to staff regular rigs with all hazards, employees, et cetera. The other thing is that I referenced the no bad outcomes thing, and just to show you, that nothing is perfect, okay? In our new system, we still are gonna have outliers. And we're going to be wrong sometimes, but not very much. Recently, just over the last couple of weeks, we had an incident where a bus driver in the middle of downtown started to have a seizure behind the wheel, moving, and people called 911. It was coded out by the information that was given as a simple seizure that was not recurrent. And so it was coded out that CMED could respond in a much more extended period of time. And meanwhile, these people are trying to get over this 420-pound person to control the bus and not make it crash. He continued to seize, then he went into cardiac arrest, and unfortunately he ended up dying. Would that have made a difference if we'd been there sooner? Probably not. But of course, the media really loves those things and will immediately come after us with our program saying, you guys are doing this and it's not working. And our response to them is, we feel tremendously horrible about what happened, but we're not going to go back to performing a one-size-fits-all system because we're able to potentially, and probably not, save this one person at the expense of having less appropriate responses to many, many, many more people in a traditional system. So just wanted to put that out there.
So we're getting ready to break for lunch. I want to tie into something that Dr. Bronsky and Dr. Daya talked about, is the finances. And Craig Dodge came up to me on the break and talked about the expense, and I'm sure that all the agency people can relate to this, as well as our hospital and healthcare system people. The expense of the crashes, the impact of the crashes, the impact of emergency response on our vehicles, the expense of running our vehicles emergency status all over town. If we refined our systems, setting the patient care aspect of this aside, if we refined our systems in any of our communities to the extent where we found $1 million, $1 million of savings in any one of our communities by scaling back this, everybody gets an ambulance, everybody gets 3 fire trucks in 7 seconds, and found $1 million in our communities, and then put that $1 million back into the community in one system that would impact the actual patients who need a response in a few minutes, the cardiac arrest patient, how would we invest $1 million in our community to have an impact on cardiac arrest patients? Anybody? We'd buy AEDs. We wouldn't put more ambulances on the road. We wouldn't train more people. The best responder to a 911 call is the person holding the phone. And how we equip them to better respond to calls, how we put more AEDs out in every location. If we can teach 7-year-old Girl Scouts how to work an AED, you know, that's the investment in the systems that when we talk about the economics, not only are we saving the vehicles, saving the personnel, reducing the risk, getting the right resources to the right patient at the right time, but we actually free up funds in our systems to put back into the systems that matter to the patients when it matters the most. And that's the patient who really does need that AED. I'm glad we get him an ambulance in 7 minutes. But how cool would it be if the guy sitting in the hallway said, hold on a minute, let me grab this AED right here and come right over. And by the time the ambulance or rescue squad got there, they got pulses back. That's the investment that as we think about the economics in some of these changes, that's where things really matter. There's running stories about King County, Washington, and there's several perspectives on how the King County, Washington system works. But I've said it before, and I'm probably at the last safety conference I said it. You can't graduate high school without an AED and CPR class in King County, Washington. You can't open a restaurant. You can't open a public space with more than 20 people, including the employees, without an AED and CPR training. Every police car has an AED, every fire truck, every public space. You do not want to take a nap on a park bench in King County, Washington, because you'll wake up with somebody putting paddles on you. However, the cardiac arrest save rate is somewhat near double any other community in the country because they've invested in that real first response criteria or item, the AED. So as we think about the economics, think about reinvesting some of the saved money into our communities, into our EMS systems, putting the saving devices into the hands of the public. We're going, Joni? There are public recognition programs for the location of the AEDs, and there are now apps, personal apps. If you want to sign up because you know how to work an AED and you know how to do CPR, you sign up for the public app, and if you happen to be standing in a building where a cardiac arrest is called in, the local 911 center activates you and says, go upstairs. There's a guy that needs an AED, and there's one in room 6. That's the EMS, bringing the public into the EMS system for the public benefit, but all of the pieces have to be working together to do that.